Morning, everyone. I'm Dr. Jennifer Cook, Vice Chair for Faculty Affairs and Education in the Department of Medicine. And on behalf of Dr. Williams, who's joining us but can't be on camera at the moment, I'm excited to introduce our speaker today. So Dr. Nasir Fakhri is an assistant professor in the Department of Neurology, but specializes also in interventional neurology. And he joined UofL's faculty in April of last year, 2024. When I look at Dr. Fakhri's CV, what impresses me the most is that he seems to be developing a collection of fellowship trainings. So he did his MD at the Medical College of Georgia, then went up to Brown University to complete his internal medicine internship, followed by his neurology residency. But he was not finished there. He then went over to Chicago to get a year of vascular neurology fellowship at Northwestern, then decided to go up to New York City and spend a couple of years there as a neurointerventional surgery fellow, both a year affiliated with Cornell and then a year affiliated with Columbia. So we are very excited that he has brought his clinical expertise to the University of Louisville and thankful that he'll take time out of his busy clinical schedule today to give us a talk on the evolution of thrombolytics and thrombectomy. So thank you, Dr. Fakhri, and you can take it away.
Awesome. Thank you guys for having me. And yeah, it's getting into it when we do our interventional practice is often a long fellowship, and we share the field with our neurosurgery and radiology colleagues. So thank you guys again for having me. I'll try to keep this from getting too dry. Sort of talk about, I know some of you guys may see some form of stroke in multiple facets, and we'll try to get you familiar with some of the trials, why we do what we do, which patients we select for thrombectomy, why we give TPA, and that way you guys can have a little bit of grounding on, some of it doesn't seem like as much of a black box in terms of what patients we take and what we can do to really treat them in the acute and hyperacute phases. That's really had a lot of development in the last, I think, 20 years. That's been groundbreaking. Okay. Just see if I can click here. Nope. So, a lot of stuff I would say happened within the last 20 years, and that's when my training, that's when I was coming up through residency and sort of beginning the fellowships. And before in the 1990s, there was, we had treatment for stroke, but a lot of stroke would happen there was only so much we would do in the acute and hyperacute phase, and a lot of our treatment would be done after the fact, after they're admitted. We would see them in the emergency room. You would diagnose the stroke. A lot of places wouldn't even have the capabilities to do, say, vessel imaging, CTA, MRIs. That came a little bit later in terms of being more widely used. And really what was done at that time was, if someone would come in with stroke symptoms, you would get the imaging, you would diagnose the stroke, and there's still a lot to be done. The same things that often cause ischemic blood, lack of blood flow to the brain, the same things that are good for the heart are good for the brain, is similar to things that cause myocardial infarction. And we would manage them with medications, blood pressure control, neuro-intensive care. Sometimes they would require a trach and peg for a certain period of time, rehab, and then get better. And some patients would do well, some not so well because of the severity of the stroke that they had. And this is just tissue that we couldn't, get back after we lost it, just because, it didn't have the same regenerative properties. And now, if you look on many institutions' stroke algorithms, it's almost infinitely complex. You don't know which patients should go where sometimes. Are these patients eligible? Are they not? Every interventionalist will have his own little idiosyncrasies on, oh, I think I can take that patient because I can benefit them. These trials haven't shown benefit, so I don't want to take the patients. And it's it can get a little bit overwhelming, but luckily, we have shown advancements in the acute and hyperacute phase that lead to really long-term benefits for these patients. And I'll try to go over some of the reasons, some of the trials that we use and that we try to quote before we do our procedures in terms of the patient selection that we have. So a lot of this evolution happened in that time period, 1995 to 2025. This time we were was kind of in the high school, college. I was seeing some of this in med school when some of these more trials were coming out. So it was a very exciting time to be in stroke care, and I think it still is. Um, and so just a little bit of semantics before I get into it. A lot of trials, when you guys probably use these in your medicine trials as well, but we often try to use disability scores. Most stroke trials you're going to hear about, a lot of stroke doctors, I'm sure this is true for all doctors, we want to use empiric evidence, but every time it's very algorithmic. A lot of stroke care, there's only so many different variables you have to calculate, and most of the algorithms we get are developed from these trials. And most of those try to use something that we call the MRS, the modified ranking scale, and the disability that stroke patients have about 3 months out. We'd like to measure them 6 months out, 1 year out. Some trials do, but they're a little bit harder. So most of the standard in a lot of stroke trials are presented at the conference uses MRS at 90 days, and I'll be talking about that in some of these trials that we talk about. And the most of what we want to get to is if patients come in with an MRS of 0 to 2, we want to keep them there. Some patients obviously that are older, they may use a cane for walking. They may require a little bit of assistance, MRS 3 as well. And then this is a little bit more higher disability. As you can see, we say MRS is more or less is dead. MRS 5 is very severe disability, requires nursing care. And the reason we talk about this is because a lot of trials initially were excluding patients that were MRS 3, 4, 5. But here, and a lot of interventionalists nowadays will take patients who might be 3 or 4, and we'll talk about why and sort of what the benefits and advantages and disadvantages of taking these patients for invasive procedures are. So starting with some of the earlier trials and why we use TPA, tissue plasminogen activator, it activates plasminogen, turns it into plasmin. This breaks up fibrin clots. The half-life is 5 minutes, i.e., it's not very long. It gets out of your system relatively quickly, but that, the effects of this last 24 hours because it changes that equilibrium where you're in this fibrin degradation phase. And that's why most of our care, this was a little bit groundbreaking when it first came out because now we could offer these patients something when we diagnose the stroke quickly and we could stop brain tissue from being lost. Their primary endpoint, sorry, excuse me for a second. Let's do this. The primary endpoint in this trial was first, is TPA doing anything, i.e., was there improvement, which is measured by the NIH stroke scale that you guys are familiar about. And then part 2, like we'll see in a lot of trials, it was just what the MRS was at 90 days. They compared giving a placebo to TPA this was only done within 3 hours of symptom onset because they knew giving thrombolytics just anywhere further along with the stroke led to hemorrhagic conversion. When tissue dies, it tends to bleed. And significant hemorrhagic conversion we know leads to increased morbidity and mortality versus doing nothing. And true to form, even within 3 hours, they said they had a higher incidence of intracranial hemorrhage, and we know TPA tends to increase bleeding. We tell patients it's anywhere from 2 to 5% can be a risk of bleeding, but we're much better at managing that bleed now than we were, say, in the 1990s. And within 3 hours, that hemorrhage was not as not as disabling as it is now. Or I'm sorry, it was not as disabling then within 3 hours, and then even now it's even better. And this is sort of a lot of scales that we're going to see on these trials. They try to show you the modified Rankin scale, show that with placebo, this is the number of patients who are going to that 4 to 6 kind of bad area, 27, 21 are resulting in nursing home, requiring assistance in all activities up to death. And when patients who got TPA, a significant number were able to stay in that MRS 0 to 2, 0 to 1. And this is really what we want to strive for all our patients, to get them meaningful interaction with the environment. And so based on this, TPA became an accepted form of treatment soon thereafter this trial, but only within the 3 hours. Even these patients had increased hemorrhage, but not so much where it was causing increased morbidity, mortality. And then, they decided how far out, they wanted to see how far out they could go with that window. And trials kind of went back and forth, and they kind of found this sweet spot where 3 hours was fine. Between 3 to 4 hours, still a little bit of increased hemorrhage, but we're still getting benefit in the MRS. And then sort of beyond the 4.5 hours, the patients were just bleeding too much. I suspect some of that was also because the last known well is always a little bit hard to pin down. And so, each patient is different, we know, which we'll go into later with imaging criteria. And usually around that 6 hours, you just for whatever reason, maybe the patient is more than 5 hours out. Their collaterals have begun to fail. They're developing a big infarct. And at that point, when you're giving thrombolytics, there's more dead tissue that tends to be prone to bleeding. So this was a European trial that was done. This was published in the New England Journal of Medicine in 2000. And even before then, they had it was well powered, about 821 patients. And you guys can see, you're going to see a lot of these bar graphs here with the colors that there were more people in the group that received alteplase getting into this area, the 0 to 2, 0 to 3, versus patients that received the placebo. They had a little bit more patients in this 3 to 6 area. So there was still, the improvement favored the treatment arm 52% to 45%. So it's there. It was still statistically significant, but there's only so much benefit when you're in the 3 to 4.5 hours window. But it was enough for people to change the protocol and say, hey, the AHA can recommendations change to say you can go out to 4.5 hours. Beyond that, it's really not indicated for this particular drug. And that's why we give, that's kind of where we are now in terms of giving our thrombolytics. We still keep to that 4.5 hour time window. And this was sort of a card that I was given when I was in residency. Just sometimes it's hard to keep track of everything you have to ask a patient when they come in immediately. Often these patients are aphasic, so you want to track down the nursing home, track down a family member. And really the main things you want to ask about is really try to pin down that last known well, because that's going to make a big difference in terms of the stroke care that they receive. And luckily, we've expanded that window to 24 hours for other interventions that we give, but for thrombolytics, which still make a huge difference in patients, because clots are not just, one form and flavor. It's not just that you have one clot. Sometimes you'll have a few distal clots in small vessels, and we really want patients who can get TPA to be able to get TPA. So if we can pin down the last known well to 4.5 hours, and then try to exclude, I know it's a lot, but try to exclude anything that causes significant bleeding that you can't compress is a risk. If you think a patient is septic, then we worry more about endocarditic things. And we know endocarditis tends to bleed. Those bacteria affect vessel walls. They cause mycotic aneurysms, and we try to avoid it. These are all relative contraindications. It's worth discussing with someone who's facile with giving thrombolytics to sort of be like, hey, this person has a carotid occlusion, but maybe he had this kind of surgery a while ago. But, we know that if we don't give thrombolytics, that it's going to be game over for this patient. So everything is a risk-benefit discussion. If you can track down the POA, even better for the patient. But, it is appropriate sometimes if you can't track down anyone and they're within the window, it's an accepted standard of care to give thrombolytics if you're able to reasonably exclude these contraindications. And make sure that we are able to control the blood pressure. I tend to jump to just a cardiac drip if people are, if they're jumping around a lot and you've given TPA, you just want to keep it below that 185 to 110. And then once you've administered it, they tell you that the new AHA guidelines are to keep it below 180 to 100. And, you can mess around with giving IV labetalol, but just for the, trying to prevent intracranial hemorrhage, you can start a cardiac drip and try to keep that blood pressure low, because stroke patients are going to be auto-regulating, really trying to get blood pressure up. And, that tends to, their blood pressure keeps spiking up after you give in thrombolytics. But a lot of the battle is done if you're able to get thrombolytics into the patient. Okay, and I just had just to keep this from getting too dry, I had like a question. I know I can't really call on people, but if you guys want to respond in the chat, if you think any of these are the correct answer, I'll kind of read through it. Just as over here, you have a 60-year-old male, comes in, history of hypertension, hyperlipidemia, AFib, not on anticoagulation, so he's a vasculopath. You get a CT, and often as stroke physicians, things we look out for on the CT are one, hyperdensity. CTs, remember, show you things that are hypodense and hyperdense. Any hyperdensity should be concerning, because any sort of bleed is a contraindication. Any bleed within the last 3 months, and some people say if you had a large an ischemic stroke within the last 3 months is a contraindication, but a small lacunar stroke versus a large MCA stroke are different, and it can be worth discussing. If someone's had a stroke recently, they're still at risk for having another big stroke. So if they come in, they could still be a candidate for thrombolytics. And what we're seeing here is just there is a hyperdensity, but this is within the circle of Willis. You're seeing blood stopping, kind of pooling over here, and we call this a dense MCA sign, and that's consistent with a large vessel occlusion, i.e. the MC, the middle cerebral artery here, is occluded. So his last known well time was 3.5 hours ago. And this is just like which of these statements is correct. TPA is a potential treatment option, but the risk of bleeding increases with longer time windows. TPA is absolutely contraindicated after 3 hours. TPA is still safe and effective even after 4.5 hours from symptom onset. Risk of bleeding from TPA is negligible regardless of the time window. Let's see if anyone responded in the chat, if anyone can put in any of their answers. Okay, that's okay. I'm just going to keep clicking through here. So yeah, the correct answer here, I would say TPA is a potential treatment option, but the risk of bleeding increases with longer time windows. And again, the big trials that we're quoting there is NINDS and ECAS. So if you guys are treating these patients, really the most important thing is getting that last known well time down. And, just about 15 years ago, we said 3 hours, call it at that. Now we're expanding it to 4.5 hours, and then we'll talk down the line. We may be expanding that window further, but we have a lot of other treatment options nowadays besides just giving IV thrombolytics. This is just one more question, kind of that same patient. You can see here, you've gotten the CTA at this point. You've given, and now you're trying to see they have a proximal M1 occlusion. Sorry, this is going to be a different patient. This is a 30-year-old female, 24 weeks pregnant, acute onset of right-sided weakness, aphasia, left gaze preference. So similar presentation, has an M1 occlusion. And this is sort of a tricky situation for stroke doctors and other people in terms of when we get into pregnancy. An M1 occlusion for a lot of people is significantly debilitating and life-ending. And these are some options you have here. TPA is an absolute contraindication in pregnancy. There is significant risk for hemorrhage for fetus and mother. It should not be offered for her, but she may be considered for mechanical thrombectomy. TPA is a relative contraindication. She may be offered both TPA and mechanical thrombectomy with appropriate discussion of risks and benefits. TPA is an absolute contraindication due to risk of hemorrhage, as we mentioned in the earlier answer, but mechanical thrombectomy is also a contraindication due to all the radiation that they get exposed to. And at that point, your options are aspirin or the next question mentions heparin, which are also valid options for treatment that we use. I'll just see if there's any. You guys are welcome to respond in the chat. You have any idea? I see someone said B. And yeah, correct. So this is sort of, people go back and forth. This is not a population that we're able to study, but we know based on other things, yes, she can be offered TPA. If she's able to discuss the risks and benefits, it's worth doing so at that point in time. Because the other thing is that there is significant risk of placental abruption, significant bleeding in multiple areas, fetal demise. But again, this in and of itself can be fatal to the mom and fetus. And same thrombectomy can be offered. It's just we put a shield on top of the mom's belly, take her down, and try to get the clot out. I would say I would offer her both. I think it's not unreasonable if she says she doesn't want the TPA, but she wants to go for thrombectomy because her procedures have gotten so good. That might be a little bit safer for the baby if that is a concern. Okay, I think this is one of the last ones in this section. So, 60-year-old male, past medical history of hypertension, hyperlipidemia, AFib, not on Coumadin, presents with acute onset of right-sided weakness, aphasia, left gaze preference. Which of the following is correct? He's not a candidate for TPA as he is on an anticoagulation regimen. So this is something you guys will see a lot as well. Just someone comes in, they're already on blood thinners, i.e. Coumadin, which is something people used to use a lot before. He's already on an anticoagulant regimen, so he's excluded, but he is well within the time window. Or because he's on Coumadin, you can check a stat INR. If it's 2.0 or below, you can give, or if it's 1.7 or below, you can give. I'll give it a second. And really kind of the important point on this question being, Not all anticoagulants are exclusions. Patients come in with big clots that are forming. Sometimes Coumadin, as you guys know, fluctuates in its INR, and we tend to say you can offer it to patients with INR of 1.7 or below. So that should be the correct answer here. Yes, 1.7 or below, i.e., if a patient comes in with a large vessel occlusion, medium vessel occlusion, sometimes like a TIA, I'm sorry, a TIA that's gotten worse and now they're candidates. So you're kind of like, was he forming a clot? Did it get better? Is it a subocclusive thrombus? You can check a stat INR, and if you're able to get that result within 4.5 hours, I think they're appropriate candidates for TPA. Okay. And now getting into sort of the beginning of the 2000s, when this is a team at UCLA. One of the members was Dr. Pierre Gobin, who had a chance of, and part of my fellowship was there at Cornell, and he invented something called the Merci device. And here, what this device does is it's a corkscrew. So you take a catheter up, and you can see right here, the catheter goes up against the clot, and then this little metal corkscrew kind of injects itself like a wine. So I think Pierre Gobin said he's French, and he reminded him of corking of a wine. He called it merci, means thank you, and so he called it device merci. And what this device did was it would sort of inject itself into the clot, stay there, and then you would pull out the whole system. And, it was able to get the clot out, but remember, we're talking about vessels these are not like cardiac vessels, which tend to be a little bit more robust. The M1 occlusions that we saw in the last few questions are about 2 to 3 millimeters sometimes. And, this can denude the vessel wall. It sometimes causes injury. And on patients who have already gotten TPA, if you injure blood vessels in the brain, they tend to be more friable and there's a risk of bleeding. So they tried to run these trials with the Merci device, and the other device that came out around the same time was something called a Penumbra. Penumbra is an industry-sponsored company as well, and they would was a device that would kind of capture the clot, create this cage, but similar problems they were having with injury to the blood vessels. And the trials coming out, that was around the late 2000s. And in 2013, they began to publish these trials where they're using these devices now. And they randomized a good number of patients, 656 patients, but they wanted to keep the time window early still, because as you get further out in the time window, we know that that leads to an increase in hemorrhagic conversion. Again, just more dead tissue, bigger core infarct, more bleeding. So trials did not want to enroll patients that were too far out in the time window. And 2013 IMS3, and I won't belabor the points on these 2013 trials, because really what they're doing is they use these devices, the Penumbra, the Merci that we talked about, and they showed that there was kind of clinical equipoise now. Before, the previous trial showed that there was actually like injury being done to the blood vessels compared to patients getting TPA. They said, just don't do the procedures. They're harming more than they're helping here. Now it's like they're not really, they might be helping. They're not causing as much injury as they were before. And there's a lot of just clinical equipoise in terms of whether they should go for the procedure or not in 2013 using these Penumbra or Merci devices, because people have gotten a little bit more comfortable with the procedure itself. People think this should work, i.e., if you remove a clot in someone who's having a stroke, just like in the cardiac, with the cardiology literature, it should lead to reperfusion, and they should get better if you can minimize the risk of injury to those blood vessels. And they said the injuries were less, but at that point, these devices were just not up to par. And then around 2013, some more private companies began to invent. They found that using stents, i.e., what we call a stent retriever. So before, stents were used sort of a carotid stent. A stent would be used to keep a vessel open, and these stents were they had some radial force, but they were not so sturdy that they would injure the blood vessel. And so someone thought of, what if you go into the clot and sort of try to release a stent there, and then keep the stent attached to the end of the catheter, and then pull that stent back in and either ingest the clot or pull the whole system out. And they found in doing this is what we call with the Solitaire, Trevo, just a number of different companies had their own version of the stent retriever. And this was around 2013. And you can see here with this gentleman with the glove that the clot just remained within the stent, and the stent itself didn't injure the blood vessel. So now you're able to retrieve the thrombus. There isn't a lot of injury to the blood vessels. And at this point, radiologists and people have begun doing this procedure enough where they're able to do it safely, minimize growing complications. We go in through the femoral artery, and they're getting safer and safer. And just a quick anatomy review on some of the vessels that we tend to go after. A lot of trials show intracranial, and that's what we look at when patients are having stroke. Of course, you can have extracranial, i.e., where the carotid origin is in the neck. You can have a carotid occlusion. And these trials, that's a little bit of a different beast. Vascular surgery deals with that, but not always acutely. And some of our trials down the line have begun talking about carotid occlusions, because sometimes you'll have an occlusion in the carotid artery that also causes an occlusion in the intracranial arteries. But a lot of the trials from the 2000s to 2018s were dealing with the M1 carotid terminus area, not as much of the A1. There's a few sharp turns here. So our trials didn't suggest a lot of benefit always dealing with the A1s, but as interventionalists, we do go after proximal A1, M1s now because the devices have gotten better. And then some of my colleagues will go as far out as M3, sometimes M4. Just remember, the further out you get into these distal vessels, that's where you begin to have injury to the blood vessels. And some of this, it may seem arbitrary, but the naming, the numbers go off the branch points. M1 is where the carotid terminus, your MCA, comes out. This is where a majority of our occlusions are. M2, we do see occlusions here. We tend to think a lot of our trials will still show benefit for proximal M2. This is after the first bifurcation of the MCA here and here. And then as you're getting further out, some people say the M3 is at the Sylvian fissure or at the next bifurcation. But remember, some patients will have a bifurcation right after the M1 here and then a bifurcation here. So it's sort of variable, but this is just a rough sketch of when we're trying to decide who we're going to take. We do this based on trials we're going to talk about briefly, but this is M1 and M2 tend to be vessel occlusion we go after, and that's where a lot of our patients get deficits, or the proximal carotid here. And I'll probably skip over these that are the 2015. Now we're sort of getting into the using the Trevo devices, using Solitaire. We are beginning to see mechanical thrombectomy is showing improvement within 6 hours. And now we're getting to the 2015s. And really the trials that I want to talk to you about more is going to be the 2018 trials. And these are the big ones that we quote now for patients who we want to take for thrombectomy. Now, at this point, radiologists, neurologists, neurosurgeons, we've gotten comfortable with the procedures. We're using stent retrievers, and we've also begun to see just pure aspiration, i.e. a catheter that goes up against the clot and you just aspirate without sometimes even needing to do a stent retriever at this point. And we need to try to figure out who is the best patient for these, because trials have shown positive results. And Greg Albers, another team in California, tried to develop software that would help us find how much stroke has already happened and then how much territory is at risk. And that's something called RAPID, where they would show you core infarct, and sort of in this color map, which we'll see a little bit in the next few slides, very pictographic representation of how much tissue you can save, how much tissue is already gone by lack of cerebral blood flow, and that'll help in your decision making in terms of, oh, this should be a patient that we should take. And Dawn was in that, and we wanted to increase the window because these previous trials are using 4.5 to 6 hours, but this is still within the TPA window where, 0 to 6 hours. These patients are still TPA candidates, but what can we offer to someone who comes, say, 4.5 hours out, 6 hours out? Do we say the same as we did back in the 1990s, get an aspirin? Sorry, you have a big clot somewhere in the brain, but we don't think this is safe for removal. But that's not necessarily true, because some patients, and they say they're last on well, what if they went to sleep? They woke up. You don't wake up with sometimes you might wake up with a heart attack because you feel substernal chest pain. You're having a myocardial infarction. You don't wake up with the stroke immediately in the middle of the night unless you try to stand up and go do something and you might fall. So there were a lot of patients who were going to sleep and their last known well was maybe 8 hours out. They went to sleep and they woke up with the stroke, but clearly on their imaging, we saw there's no completed infarct and we see an occlusion. So we wanted to go after them, but we didn't have trials that told us that it would be safe. And, previous trials back 20 years ago showed that there's injury to blood vessels. So we had to really discuss risks and benefits with patients. And now this trial comes out, Dawn, where the last known well is 6 to 24 hours, and they used a clinical deficit, and they want to use a small core, and they sort of stratified this by age. People greater than 80, they didn't want too big of a core. They said about 21 cc's. Less than 80 gave you 31 cc's, and the core was based on the perfusion imaging and the patients were also required to have an MRS of 0 to 1. They didn't want to get patients that had an MRS of 3 to 4 just for this trial because it'd be hard to show benefit in someone who has an MRS of 3 or 4. That maybe you still save them, but there wasn't an improvement in their MRS. And this trial really wanted, like any trial, wanted to show positive results. And you guys can see in this pictographic representation here, the patients taken for thrombectomy versus the control group, further along the line being kind of the bad group, the MRS 4, 5, 6. It was a very significantly positive trial here. There was no significant difference shown in 90-day mortality, but the number needed to treat here was 2 to 3 for functional independence. There isn't a lot of things in medicine that we say like the number needed to treat is about 2 to show a statistically significant difference. And that's why we were excited about this trial, because this gave an option to those patients who come in within up to a day. And then we can use imaging criteria and try to give them a treatment option and give them something that we can do acutely for them. And this is sort of those maps that I'm talking about here. The pink shows lack of cerebral blood flow. On a non-con head CT, this would just be a hypodensity. And then this is 2 points that software has picked. And it shows, we call that Tmax, and that's the time to get from one point to the other. And when that flow point is greater than 6 seconds, it turns green. Greater than 4 seconds, it's blue. That shows us a little bit of slow flow. And then greater than 6 seconds, we call that penumbra. And in the core, you do see greater than 6 seconds because there's almost no blood flow. So it showed us what was completed infarct, and it showed us kind of what could complete this software that we call rapid imaging. And these trials were both published next to each other, Diffuse 3 and Dawn. And this was a little bit more on that imaging criteria. Diffuse 3 uses 16 hours, and they tried to increase that core to say, let's use a core of 70 cc's, mismatch ratio 1.8, and a lesion of at least 15 cc's, i.e. it was nothing. They wanted to show that there could be some core and there could be some benefit to that. And just skipping over this a little bit, the median core in this group was about 10 cc. So they had some core, but they had significant penumbra at risk. Some people were up to 100, 150 penumbra. And again, a very positive trial. Dawn and Diffuse 3 were some of our seminal trials in our field. This was in 2018 when they were published. And they were doing this where I was doing residency. We were one of the sites. And there's just a lot of patients we noticed that were going for thrombectomy were doing so much better. There was more favorable distribution of disability scores. Here you guys can see kind of very clearly patients who were getting medical therapy. And unfortunately, so we're looking at patients here who are 6 to 16 hours out, up to 24 hours out. So a lot of these patients weren't getting TPA. So we're going back to, neuro ICU care, medical management that we could do after the fact, but we want to do something really acutely to save much brain tissue as we could. And then you guys can see here in the endovascular therapy group, just a large portion of patients remained here in the MRS 0 to 3. And then, in the patients who didn't, a lot of them ended up with some significant disability, especially when you have an occlusion of a middle cerebral artery or a distal carotid. Often the mortality we say for carotid occlusions is very high. And then taking that one step further, which I think is going to be a little bit more some of the future. This was published in 2020. Is now we've shown that we can do thrombectomies, we can remove the clot, but what about? Is there anything we can give because the catheters are already there? Neuroprotectants, neuroregenerative agents, and they did a trial with something called nerenatide. This was a protein. It was a peptide that they used IV in a monkey population that showed a reduction in the stroke core, sort of some reversible DWI, reversible diffusion restriction in stroke patients. And they wanted to inject this along with taking patients for endovascular treatment. This wasn't done intraarterially, but IV. And primary outcome, they just wanted to show that is there a role here for neuroprotectants as well as doing thrombectomy for patients in that 24-hour window. It was, again, showing primary outcome was MRS is 90 days. And what was interesting about this trial was it wasn't a positive trial. You guys can see kind of looking at the colors here that, it looks about the same in terms of people who ended up with the MRS, the higher MRS group here. They didn't say it was necessarily statistically significant, but they did a secondary subgroup analysis because this included a lot of patients who came in within 6 hours, and patients got TPA. So they got TPA and they got nerenatide, but they noticed that people who got the thrombolytics were doing more poorly compared to people who didn't get thrombolytics, which is a little bit strange because they came in so quickly with the neuroprotective agent. And they found that there was actually a pretty significant improvement in patients who didn't get alteplase, which was a little bit strange because you were like in this little sliver of window, like 4.5 to maybe 8 hours out, because after 8 hours, they begin to have a little bit more stroke. And so there is, someone did some lab work finding that the neuronatide actually interacted the tissue plasminogen, that fibrin cascade was affecting the neuronatide and maybe chewing up some of the protein. And so they're running more studies, I think, down the line showing the role for these neuroprotective agents acutely. We think maybe, or if not acutely, maybe even chronically down the line in some of our rehab patients. And so just one or two more questions we have here. 60-year-old, hypertension, hyperlipidemia, AFib, not on anticoagulation. His stroke scale is high. You see the hyperdense vessel. Last known well now, we're way beyond the 4.5 hour window. We're at 15 hours. What do you do next? And we'll see if anyone chimes in on the chat. And just reading through these kind of at this point where within Dawn and Diffuse 3 criteria, and these trials were, multi-center randomized, hundreds of patients, and we have enough evidence to suggest that this is, that we should at least get further imaging. We get a CTA, you get CT perfusion, and he can be considered for thrombectomy. So should order CTA and perfusion imaging would be correct here. And then again, looking at this photographic representation for another patient, a 60-year-old, same patient, shows an M1 occlusion once you've gotten the imaging. You see this, he has a large core, but there's 120 cc's of brain tissue that's going to be lost if you don't do anything. He's about 15 hours out. Usually within 24 hours, we really want to give patients the benefit of a doubt and take them if we can. And 60 cc's in my mind is not as big of a core. We used to be scared of that because of the reperfusion hemorrhage, but a lot of our trials are now showing that despite, even if patients bleed, if you're able to save another 60 cc's of brain tissue, well, it's usually worth it. And the trial will support it. He's less than 70 cc's per diffuse 3 criteria. It's worth call, and any of these patients, like I'm sure a lot of you guys will know, you can always call the stroke neurologist or the neurointerventional team, have them look at the imaging and decide, we're more than happy to take a look and then de-escalate rather than, miss someone who may be able to help here. And this was just I guess I'll finish up with just, this was a case that we had in residency that was a little bit one of these in-between cases. An 80-year-old came in, hypertension, diabetes, AFib, was not on anticoagulant. And she came in with aphasia, right-sided hemiparesis prior to arrival. Came down to examine the patient. And at that point, she was looking like a MCA syndrome when she was in the ambulance. And you guys will see this sometimes in the ED. The clot either recanalizes or the clot sort of begins to have blood flow beyond it for whatever reason. Sometimes she has collaterals, and now she's almost asymptomatic. She's improved. So you're like, was it a seizure? Did something else go on? She feels back to baseline, and what do you do next? And at that point, she had an MCA syndrome. Yes, seizure should be on the differential, but also it's worth getting a CT and getting some vessel imaging just to find out what's going on. Why does she have this? And you get your vessel imaging and you see that she does have an M1 occlusion. But just because someone has an occlusion, and if you catch them really in the early phases, they have all these other vessels that are sort of like you've blocked the main road, but they have these little detours that are supplying this blood tissue. And that's what that green area is showing us, this penumbra. And, she's fine now, but it's kind of, she's an 80-year-old. She's, our trials were suggesting people should be a little bit more gentle in the older population. She's within an hour or so, but her stroke scale is 0, and NINDS, ECAS, none of the trials were giving thrombolytics to patients with a stroke scale of 0. So it's sort of, what do you do now? She has a clot, but could that have been chronic? Some people have ICAD, they have chronic MCA occlusions, and then they just sort of have collaterals that they built up. And we know opening up chronic occlusions is not something that has shown benefit, just because they have sort of their own internal system that's compensating for it. So that's why, if you're worried, is this something that's chronic or not, you can get what we have now, perfusion imaging, to show, it looks like she has a penumbra, she's at risk here. And this is an area we're just not sure. Like there is slow flow. We know that T max, that time to get to this area is slower. And that could be because she's built up collaterals, or that could be because something's happening acutely. Her clinical presentation when she came in the ambulance makes you suggest that something could be going on. So we will, at that point, she has that penumbra. She doesn't have any core. She hasn't infarcted because, it looks like that was a very transient event. Options that are valid that you could do here. Honestly, there isn't a right answer. Give TPA, admit to NCCU, kind of give fluids, observe, wait till she declines. You could start, people talk about starting a heparin drip for patients if you see an acute clot, if they're not a candidate for TPA, or, you intervene now and you do an angiogram. Remember what we do, the interventions are not just benign. While they are, somewhat minimally invasive, they're still quite invasive. We go into a femoral artery. There's a lot of risk of bleeding. Wires and catheters are going into small vessels in the brain. And, our previous trials showed that often that caused injury. Dispo home, I would say, is probably not the right call here. And there's just kind of a stock footage of often what we see. She's admitted to the unit. They started heparin. They are like, why don't we try a heparin drip, see how she does, kind of give her fluids, lay her flat. And just like we expected with that penumbra, as time went on, heparin's not therapeutic immediately when you start it. She kind of decompensated later in the evening. It's almost like, oh, you should have done it, maybe just taken her earlier. But at that point, she's decompensating. Now her stroke scale's in the teens or 20. You've already gotten your perfusion from earlier. She has a lot of brain tissue at risk. And they ended up taking her, got the clot out. She had like mild deficit after the procedure. She had like this little facial droop, nasolabial flattening. And then she went home on some anticoagulants. And sort of the question is, because she had AFib, where the field is going to go now. Our system has changed over to using tenecteplase. A lot of trials think we want to expand the TPA window. Time is still brain. You guys have heard that a lot, but I think there's a lot of inter-individual variability. Patients in Kentucky sometimes will come in with, if you're prone to smoking, you tend to have carotid occlusions, different occlusions within the brain, what we call ICAT, intracranial atherosclerotic disease. So they have interesting collaterals built up. Our imaging can keep advancing to help us show what's penumbra, what's completed. We have something what we believe is almost reversible DWI. If we catch an MRI, we do MRIs pretty quickly here, and sometimes you can see diffusion restriction that we say correlates with cytotoxic edema, but some of that is reversible. Our devices continue to improve. Many companies have gotten into this stent retriever and aspiration game now, and just recently, within the last 2 years, we are going after what we call large core. Diffuse 3 said beyond 70 cc's is large core. Dawn talked about more than 2/3 of a territory being infarcted of the middle cerebral. It's not worth it. That's a low aspects. And trials are now showing positive results in the going after larger core patients because they just do better even with increased bleeding. And sort of the stem cells, neuroprotective agents, regenerative agents is something people are trying to get excited about because our catheters are already there when we've removed the clot, and it's can we do anything else after the clot's removed to help the patient? And I think that's about it.
Thank you so much. That was a great sort of review and kind of journey through the years. And whenever I hear talks like this, I feel justified in why I don't always know the answer to what should happen with the patient next, because it sounds like it's ever changing. Um, we have time for questions. I'll start us off with a question. One thing that I noticed in the data that you presented from multiple trials is that we don't seem to have moved the needle on reducing mortality with these interventions. And, it's an interesting, I guess, thought experiment or ethical question as well, because how many people want to be moved from a rank of 6 to a rank of 5, if that's where they would end up?
Yeah.
But I wondered if you could comment on why you and other experts feel that we're making more progress with reducing morbidity as opposed to reducing mortality, or am I under the wrong impression from the data?
You're right I didn't harp on this before in terms of this MRS6 was diffuse 3 and Dawn did show a reduction in mortality as well. You can see, 6 is mortality. So the medical therapy, there was a reduction here, sort of 26-14. But then you're correct in terms of the earlier outcomes. The mortality wasn't necessarily changed in terms of these earlier trials with the stent retrievers. And I think that might have just been maybe a function of certain patient selection, like the patients who don't do well, probably because of medical comorbidities. Like what if they have bad, like CHF, they have, end stage renal disease, other things going on that they had a clot and they're we're even if you're able to remove the clot it was just I think it's one of these kind of medical substrate that didn't change much overall, but I think it's a good question. But I will say the Dawn and Diffuse 3 is really one of our landmark trials, and they did show reductions in mortality, if I'm correct, but there wasn't in the earlier ones in that 2015 where they're like the devices are working but we're not, why aren't we changing the mortality? I think that's a good question. I don't have a great answer outside of I think some of the patients that were included were probably just very sick
Really
and
sick.
didn't
Yeah.
matter what you were gonna do, and there. But then like there were some that you were kind of like that did well, and the ones that did well were gonna just get better in their morbidity at least, is what I suspect was something like that going on.
Great. Thank
But I
you.
will say the Dawn and Diffuse 3 did show, in those patients that we use image guided selection, that's where we
Mhm.
really, I think that changed the game because you could tell this is how much stroke they've had, this is how much stroke they're gonna have. And so they wanted to show, you made up a great point. They're like, we need to show there's both morbidity and mortality. So like they excluded patients that had a large core that I think would have had increased morbidity. I'm sorry, mortality, like
Mhm.
i.e., small core, large penumbra. These patients didn't tend to have the increased mortality, and that's why they were able to show a benefit in the mortalities as well.
Gotcha.
14% in the thrombectomy versus 26% in standard medical therapy. So there was a significant reduction for mortality and morbidity. So it was kind of helpful there. I think when you started to use imaging. So I think sorry, I'll go back and say the previous ones didn't use that imaging criteria. So I wonder if they took patients that just had large strokes,
Mhm.
large core, still took them, and they were, doesn't matter if you opened it or didn't open it, they had a big stroke, they were going to have cerebral edema and probably kind of completed into that mortality subgroup.
Makes sense. Thank you. Do we have any other questions? I think Dr. Williams texted that he was having some connectivity issues, so I'm not sure if
Oh.
he'll be able to ask a chair's question. But I'll open it up to the audience if anybody wants to unmute or put anything in the chat. We have one question in the chat from Dr. Sarakbi. Any different approach for patients with APS on warfarin? So that's
Um,
anti-phospholipid antibody
yeah,
syndrome.
that's a good question. We like to use in terms of long-term, I'll answer two parts. So long-term therapy, we want to use DOACs for patients because it's so hard for patients to use Coumadin. But this is one of those syndromes that we know that, the recommendations right now are to use Coumadin for treatment for antiphospholipid syndrome. Luckily, in the acute phase, the trials didn't like select patients with antiphospholipid syndrome, but if they have a clot and they come in within the window, they're TPA candidates. And if they are, if they're on Coumadin, same thing as before, it doesn't matter what reason they're on Coumadin for, you check the INR. If they're subtherapeutic on their INR 1.7 or below, within 4.5 hours, they're TPA candidates. If they have a clot in one of the blood vessels, carotid, MCA, or favorable mismatch, going in there with mechanical, i.e., trying to remove the clot is still valid because you're going to restore blood flow. It doesn't matter what caused the clot, more or less. Now, I think post ED kind of interventional course might be a little bit different because they're sort of, the stroke mechanism is a little bit different. But acutely, you would treat them the same, i.e., they would be candidates.
Thank you.
Yeah.
We have another question from Dr. Krishnan.
Mhm.
Fusion CT also needs to be read in a timely manner. Are we over reliant on Rapid or Terra to make clinical decisions?
No, that's a good question. So the perfusion, I'll show you guys on sort of, I'll just pull up my phone here. So as the interventionalist on the call team, when we get a perfusion imaging, the interventionalists, we read the perfusion, and what it'll show us is it actually comes through to us even quicker than the moment the perfusion gets done in the hospital, it comes through on an app on our phone, and you guys could see kind of, we get this picture that comes up on our phone. Oh, that camera is not great, but here, let me see if I can focus that better. Probably because it's blurred. So it comes up immediately to us, and we can make that decision as the interventionalist. Just be like, hey, it looks like there's a good penumbra here. So the interventionalist, or when I'm wearing the hat, is the stroke doctor. I call the stroke doctor. We find out, hey, or if I'm the stroke doctor, this is the clinical syndrome the patient's presenting with. We'll look at the perfusion ourselves. And then the app will also show us actually we can scroll up and down on the vessels, and we're able to the rapid just it's a way for me to get access to the imaging quickly, but it's as like AI function, it overcalls, it says all kinds of things. We don't really rely on them to interpret the image, but it's a good way for me to get access to the image. So I don't have to like log into a computer and wait for Cerner to upload it or something. It comes very quickly to us, even before it's sometimes up in the computer system in the ED. And that way we can see what the perfusion shows, we can see what the vessels show, we find out what the clinical syndrome is, and then based on we might cite Dawn or diffuse 3, be like, hey, look, there's a 70 cc core, but there's still 120 penumbra, patients within 24 hours, they have a stroke scale of 20. Let's go ahead and take them down for thrombectomy.
Yeah. Time is of the essence, so that's an excellent use of technology.
Yeah, it's a nice way for us to get some of these images, but we in terms of interpretation, there is an AI function, but it tends to like brighten up. It'll highlight a vessel that it thinks is of concern, and it'll say possible elbow, but more often than not it overcalls. Luckily it doesn't undercall as much, but it tends to. So we always sort of look at that. And we if you're doing the procedure, we kind of look at the course we're going to take and which vessels we're going after, and things like that.
Very good. All right. Well, thank you so much. I don't see any more questions. So we want to just thank you very much. So obviously they are keeping you very busy on the interventional service. And so it means a lot to the Department of Medicine that you take the time out to give us this talk. And I think, Jason, do you have a little token of our thanks?
Yeah, Dr. Fakhri, we have in the Department of Medicine, we have a little tradition for you're not really a visiting speaker since you're probably just up either, I think you may just be downstairs from us or whatnot, but but anyway, we have a little token for our speakers. So we will be getting you your very own personalized Louisville Slugger bat.
Oh, amazing. Thank you.
Yeah, so we'll get that. I'll get that to you. So we really appreciate it and a great talk. And we always enjoy our annual visit from our friends in neurology. And it was another, it says great information, and we really do appreciate it.
So, yeah, thank you guys for having me. It was a pleasure.
All right.